Hey everyone, big news! We've launched a brand new Beyond the Mask website, professionally redesigned to give you a better experience. It's easier to navigate, better organized, and makes it simple to find episodes, explore our exclusive series, and access helpful resources for CRNAs, including CE credits and the 1099 CRNA Institute. Check it out at beyondthemaskpodcast.com. CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to the Beyond the Mask podcast. This is the Anesthesia Alchemy edition. Join hosts Gary Bridges and Lynn Maxey as they deep dive into today's most important clinical conversations.
Welcome back to Anesthesia Alchemy, Lynn and Garry Unplugged, and I'm Lynn. And Gary, I have some amazing news to share with you, and it's related to the topic we're discussing today.
Fantastic. I can't wait.
I've just gotten a book published on becoming prepared for our own death, which sounds depressing,
Wow.
but I think it's important to be prepared before a crisis with the medical system. This book, I named it, It's Not If, It's When. And the byline is what you need to know, decide, and share before the end of life. So before attending anesthesia school, I worked in an ICU a little over 2 decades. Did you know that?
I did.
I went back to school when I was elderly.
Yeah.
On nearly every one of those days in the ICU, I sat with patients and their families who had very little understanding of what we do and why we do it, or how our interventions affect their hospitalized or critically ill loved ones. And I quickly came to understand these issues affect patients and their families when a loved one needs surgery and anesthesia. And I can only imagine how many of our listeners have faced this with at least one of their patients, if not members of their own family.
Absolutely.
So all of what we face, either in the ICU or the OR, is just one of those quiet, grinding realities of healthcare when patients and their loved ones are thrust into these circumstances that require medical literacy, emotional readiness, and decision-making skills involving complex situations that they've never had to navigate. It's kind of like these people have been dropped into a foreign country without a map, where they encounter an unknown language and customs. This book is a gentle and practical guide on the subject of death, helping you find the words to start essential conversation and the dying process itself, to understand the signs and symptoms to expect, those kinds of things, as well as making decisions that ensure comfort and dignity for yourself and those you love. So today we're going to step into this conversation that sits at the core of what we do, but is rarely talked about openly or honestly. And this isn't just a clinical topic, it's a human one, and it touches every provider at some point in their career. Before we begin, we want to acknowledge that today's episode discusses death, dying, and emotional experiences in healthcare. And if that feels heavy, we encourage you to listen in a way that feels very safe for you.
Yeah, Lynn, and I think what really makes this conversation difficult, particularly for our healthcare workforce, is that it forces us to really confront something that we're actually trying to work against, right? Death is inevitable, yet medicine often treats it like something to defeat or delay at all cost, and we've all witnessed that, particularly in the ICU. And that tension really creates a lot of internal conflict for healthcare providers like especially ourselves in high-stake environments like anesthesia. Even though we encounter death more frequently than most people, that exposure still doesn't necessarily make us more comfortable with it. And it's more present for us because we're there. And sometimes it gets a little complicated for us to really wrangle with.
It's not an easy subject. And in many ways, we don't start thinking deeply about death until something disrupts our normal rhythm of life. It might be a diagnosis, the birth of a child, a loss, or a case that stays with you longer than expected. And these moments force us to confront these questions we've been able to avoid. And especially in American culture, death is often seen as an interruption rather than a natural conclusion. The denial of death in America. And that perspective changes how patients, families, and even providers approach end-of-life care.
Yeah, and when you look at anesthesia providers, we exist right at the boundary between life and death, consciousness and unconsciousness, which we control, sometimes unpredictably. We're the ones that induce the anesthesia, manage the airway, titrate the medications, respond when things go wrong. And in many settings, particularly CRNAs, there's really no buffer or diffusion of responsibility in these circumstances, right? And
right, very much so.
Yeah, and so when you have a case and there's a poor outcome, that emotional weight lands directly on the person who was there for every second of it, and that being us, right? And that's a level of accountability that both professionally and deeply personal, which kind of goes into, there's other segments that we've done on other episodes called The Second Victim. And this part plays some of that, but we're diving in a lot deeper today.
And what frustrates me is that what makes this more complex is that despite carrying the weight, anesthesia providers, especially CRNAs, are often not included in the conversations that follow.
Yes.
The residents, if they're in the room, they may be, had a chance to talk with the anesthesiologist, or they're supported, in my experience, more so than the CRNAs are. And you may not be present in the family discussions, ethical deliberations, or even the institutional reviews in the way other providers are. And yet you hold the most complete narrative of what actually happened in the room.
Yeah.
There's not always a resident or an anesthesiologist. Most often there's not. But that disconnect creates a kind of emotional isolation that doesn't really get acknowledged nearly enough. So we're going to call that today the silent burden.
Yeah.
That is not original with me, but it's the silent burden that all anesthesia providers, ICU nurses, all those people, all of the healthcare workers have to carry. But I do think that there's a special edge and an increased isolation with CRNAs.
Yeah, we really want to normalize something right from the beginning, right? Like discomfort in this line of work is not a sign of weakness or inadequacy on the provider side, right? It's a sign that you're actually engaged and that you do care and that you really understand the gravity of what you're doing. And every provider, no matter how experienced, will encounter moments like this that will really rattle and shake them to their core, And that's not failure of preparation. It's the reality of working in a profession that really intersects with ultimately morality and mortality, right? And the absence of feeling would actually be far more concerning, I think. We all will bear that gravity of the impact of someone passing on us or having a bad event.
And having to keep it together right after the event, if you're still in the OR, and just to be able to maintain professionalism, but to stuff that down so that you never acknowledge the feelings or the frustrations or the pain of that.
Yeah.
I mean, discomfort is often a reflection of integrity or empathy and presence. It means you haven't completely disconnected from the human side of this work. And while that can be painful, it's also what makes compassionate care possible. So today's conversation isn't just about patients and outcomes. It's about how these experiences shape us as clinicians and as people.
Yeah, Lynn, and anesthesia is a specialty that's really built on precision, anticipation, and most importantly, control. We're
we
trained.
Love that word.
Yeah. I mean, we're trained to manage physiology with incredible accuracy, and predict many of the responses from the drugs that we give, the interventions before problems actually occur. And that training really creates, a strong professional identity that really is rooted in mastery, right? And that's an implicit belief that if we are vigilant enough and skilled enough, that we really can prevent bad outcomes, right? But over time, I think over the course of our career, we learn that this belief really is only partially true.
Right.
Because we do lose patients, unfortunately.
And even if they don't die or pass away, there can be really poor outcomes from having surgery and anesthesia that isn't tied to our care in any direct way, but they're so sick. There's so many really, truly sick patients in the hospital anymore, and they come in for surgery. But that's because we actually control physiology, not fate.
Right.
And that distinction becomes clear with experience, often through really horrible, difficult cases. I mean, you can do everything right. Follow all the protocols, anticipate complications, respond appropriately, and still have an outcome that doesn't align with your expectations. And that realization can be deeply unsettling because it challenges the foundation of how we understand our role. It forces us to pretty much reconcile skill with uncertainty.
Yeah, and patients don't necessarily see that nuance, right? I mean,
No, they don't.
Come in for surgery expecting safety, expecting predictability, expecting a good outcome, and that's not always the case. But, we become the embodiment, really, of that expectation, whether we acknowledge it or not. So, when outcomes don't align with sort of those expectations, either patient or provider, it can feel like a personal failure, and it often does. But it's not a failure. That emotional weight is something that providers carry long after the case is over, and sometimes years to decades. And that's why I think this episode is really important to help individuals to kind of deal and grapple with some of that.
So how many places that work have a death in the OR or a really poor outcome, and then they expect the CRNA to just turn around and go get the other patient?
Yep, next case.
I think that's incredibly unfair and even dangerous because, half of that CRNA's brain is still focused on the previous case.
Yep.
The last place that I worked, if you had an unfortunate outcome in the OR, you were allowed and asked to come out of the OR and you could go home if you wanted, or just go sit in the break room and let people come in and give you hugs and talk to you, or go get a cup of coffee, which I think is extremely valuable.
Yep.
To help with all of that sadness and weight. But there is another layer to this, which is moral distress. This occurs when you're involved in care that doesn't align with what you believe is in the patient's best interest. And how many of us have faced that?
Ooh, yes.
They brought a patient into my OR one day. He was this elderly man. He was a full DNI, but they wanted me to intubate him so that they could do a needle biopsy in the neck, just so that they could know what kind of cancer he had.
Oh, God. Wow.
I was livid that they talked this little man's wife into this. Like, what's the point in academic exercise?
Yep.
But so many times in anesthesia, we're always managing the physiological consequences of decisions made by others, whether it's surgeons, systems, families, or circumstances beyond our control. And we witness suffering or interventions that feel excessive or futile, but still be responsible for maintaining stability throughout. That creates a tension between professional responsibility and personal ethics, in my opinion.
Absolutely. And all of this exists within a culture that really values sort of the quiet competence, if you will. People can define that how they wish. But, we're expected to be calm, composed, focused, even in the most intense situations.
Right.
And there's very little space in that sort of culture that we function in for openly processing emotional responses, uncertainty. And over time, that expectation can actually lead to internalization of, as you've referenced, Lynn, where providers really carry their experience privately, which is dangerous, rather than sharing them, right? You need to share them with somebody, and having that mechanism, whether that's in your department or somebody to call and kind of debrief. And that's where that, I think that silent burden begins to grow.
Like mushrooms in the forest. I mean, it's just, how do you come down from all of that? How do you learn how to cope with those feelings? But when we talk about death in the clinical setting, I think it's really important to recognize that it's often not sudden or dramatic. Many patients, and I've had several of these little elderly people that they really just deteriorated in this slow and terrible way during the anesthetic, and you're titrating drips and getting their pressure up. But these are patients that are considered frail or don't have a good reserve of energy. Their MET scores are low. These patients, in particular, represent a loss of physiological reserve. So they're vulnerable to even minor stresses, and surgery and anesthesia are both unbelievably stressful. These are the patients who don't bounce back the way we'd want or expect. Instead, each hospitalization, each time the patient comes back, either in the hospital or to surgery, it results in a stepwise decline.
Yeah, and what we see over time is that this distance between crisis becomes shorter, patients recover less fully with each event, and, their baseline function continues to erode. I mean, that's, I always tell people, as we age, I look at it like the treads on a tire, right? And some of these things we can't change. It's going to happen. And eventually we reach a point where, interventions are no longer restoring health, but are actually simply delaying the inevitable,
right,
as you've alluded to, Lynn. This is really where the concept of rescue begins to shift, right? What was once life-saving now becomes life-prolonging in a way that may not even benefit the patient. And you've alluded to it. And I can't tell you how many times that I've cared for patients that were in their 90s, like mid to late 90s. And you're like, oh, what's the goal here, right?
Well, so I was working in the ICU one day, and they brought this little bitty old lady in from a nursing home, and they're coding her. They bring her into my room. They insist that I be coding her. I am breaking every single rib in her frail little chest. And there's this doctor standing at the end of the bed. And I just turned to him and I said, what's the goal here? What are we aiming for so that we can save this little bitty thing, this little lady, to send her back to a nursing home?
With now cracked ribs.
With now, but she'll go back with a tube feed and
and some chest tubes.
And some chest tubes.
We don't mean to make light of it, but I mean when you reflect on some of this, it's and I had the same scenario when I was working in the ICU. I was just a young beginner, right? And I remember I came in onto my shift, same thing, old frail lady, cachectic. She crashes, they hit code button and come in, and the pulmonologist tells me, go ahead, get up and start doing chest compressions. And at the first push, I could feel at least 6 ribs cracking under my hands. And I'm what? And he goes, yeah, that's just the ribs. I said, same thing. It's like, what are we doing here? Why are we trying to resuscitate a 90-year-old that's clearly is trying to exit gracefully, right? And we took away that grace.
So one of the things I talk about in the book is it's very important for people to talk about the end of their lives, what their goals are, what they want, what their values are. If they don't want CPR, if they don't want dialysis or chest tubes, they need to communicate these things to their family, and they can have multiple conversations. The book goes into how do you start? When do you start? What kind of a space should you begin this conversation? Because if your family doesn't know what your values are, what you want at the end of your life, the hospital is this machine and it's all moving towards resuscitation.
Yep.
And if you don't want that, you have to communicate that with your family, because most likely you're not going to be able to speak for yourself. I find it so important to try to help people prepare for their final days so that they can live fully until the day they pass. And that may include CPR and dialysis and all of those things, but it may include comfort care. What point do you want to say enough? And how your family can help you create that with the living will, and they come forward and they tell the doctors, no, we didn't want this done, kind of a thing. Even if I didn't write this book, I wish that everyone would read this so that they could become prepared and understand the hospital maze, what code status means, all those kinds of things, because you have to address it before a crisis.
Yeah.
Because modern medicine is incredibly effective at rescue, especially in acute reversible situations. And, when you're young and you have a good quality of life and you have good body reserve, absolutely go for every second of resuscitation. Ventilators, vasopressors, they're all designed to stabilize and restore function. But those same tools, those interventions can have a very different impact in patients with advanced or terminal conditions. And in those cases, interventions may extend the dying process rather than improving the quality of life. And recognizing when that time comes can be one of the most challenging aspects of clinical care, and also a very important one to stand up and help the family understand what's going on.
You've probably wondered at some point, should I stay W-2 or go 1099? And more importantly, what would that mean for my income? AANA has launched a new 1099/W-2 income comparison calculator designed to help you compare W-2 compensation with potential 1099 earnings in just minutes. It also helps you understand how taxes, deductions, and expenses could impact your take-home pay. It's a quick, simple way to get a clearer picture of the numbers before making a career decision, whether you're actively considering independent practice or just exploring your options. Try the 1099/W-2 calculator today and see how your potential earnings compare. Visit aana.com/1099 calculator to explore the tool, or check this episode's description for the link. The 1099/W-2 income calculator, helping CRNAs better understand the financial side of their career choices. Remember, that's aana.com/1099 calculator.
And sometimes it's rarely a clear-cut moment. There's no definitive point where everyone agrees that, hey, the focus should shift now, right? Instead, it's something that us as clinicians feel, an accumulation of evidence, if you will, the experience and intuition, which is a gift that we develop over time in our careers. And you begin to recognize some of these patterns, and you see when recovery is probably unlikely despite continued interventions. And the system doesn't always support acting on that recognition or intuition. And as we're chatting here, this brings me back to the ICU. And I remember an elderly gentleman that was the blue bloater, right? He was the emphysema patient.
Right.
And we don't see many of those anymore. But I remember he would come and get admitted to the ICU, saturations in the 70s. I mean, he lived in the 80s with, 2 liters of oxygen, and we always had to balance that so it didn't kill his hypoxic drive. But I watched this man suffer, and I was like, it was for about a year, in and out of the ICU, and I was just like, what a horrible life. And
right.
Then I remember the night, obviously when you get anoxic and stuff, you start to panic because he's trying to breathe, to a sign of life.
It feels like you're drowning.
Well, yeah, exactly. And I remember going into the room this one night, he was still, a full resuscitation. And I remember seeing him starting to struggle, but he was giving up the fight, right? And I called the pulmonologist and I said, you really want us to resuscitate Robert? And he's like, well, we have to. And I'm like, I don't think we have to, right? Like,
good for you.
Do we need to let him go through this pain? And so the pulmonologist, he says, I'm on my way in. So he comes in and we let him go. You know, and I think there was a young daughter that it was just so traumatizing watching her go through her father's, you know, agony
right.
and pain. And you're just like, we're not going to fix him unless you give him 2 new lungs, you know?
Right.
So.
But that's so hard for the daughter and the patient, but the daughter's going to be around to, did I do the right thing?
Yep.
You know, did dad want everything done, or did he want comfort care? Because a conversation clearly hadn't been had. That
Right.
was a terrible way to say that. The two hadn't spoken with one another about these kinds of things. And my parents did that for me. And I am so thankful because I was able to help both of my parents die, quote unquote, a more natural death. Even though my dad was in the hospital, he did not want to be intubated, and he was in florid pulmonary edema after a massive MI. And I was able to talk to his hospitalist and say, look, I don't care if my dad's respiratory rate is 2. If he's grimacing,
Yep.
he cannot survive this. If he's grimacing, that tells me he's uncomfortable. I want him to be able to have morphine. But if his order is a strict, he can only have it so often, that's not going to work. And he made the order whenever I asked for it. He could have it. He only got 3 milligrams the first time, and 2 hours later, or 1 hour later, got 2 milligrams, and he died about a half an hour after that. But he was resting.
Yeah.
He was going to die no matter what.
Yeah.
So to be able to help him die without all of the machines and the CPR felt like a win. But this is what brings us to one of the most difficult questions in medicine. Just because we can intervene, should we?
Right. Absolutely.
And that question, but you know, when you were talking about earlier, you had to stay open and just open to the process of Robert's dying.
Yep.
To be able to go, hold on, I understand the system is all about charging towards the horizon,
Yeah.
but this isn't the right thing to do. And you interrupted that machine so that this man didn't have to continue to suffer.
Right.
But this question doesn't always have a simple answer, but it's one that really deserves our attention. Because there comes a point when the kindest and most appropriate care is not about extending time, but improving the quality and maximizing the stability of the patient and their comfort with the time that remains.
Yeah, you know, Lynn, when we move into sort of these ethical and legal sides of end-of-life care, it brings even more complexity, right? You know, on paper, advanced directives like living wills are really designed to provide some clarity about what patients' wants and needs are. But in practice, they often fall short because they're written in broad, non-medical language. At least that's been my experience. Terms like no heroic measures, no extraordinary...
Right. What does that mean?
Right, yeah, you know, no extraordinary interventions. It sounds clear, but they don't really translate cleanly into what clinicians are doing real time and certainly
right.
the decision making in their mind, you know. So in the middle of all that crisis, providers are left trying to interpret something that is so nebulous without any kind of context. And then that adds more uncertainty and I think frustration in the provider side, because you're like, I want to do what the patient wants and respect their wishes, but I don't know how to interpret this, you know?
Right.
So then you default to like go full bore, right?
So in my experience, the living will only does one thing. And a patient could have 100 living wills on their chart, but it only does one thing. It backs up the family when they come forward as a cohesive unit, and that's the important part. If there's one straggler, a son or a somebody, a close-knit part of the family comes forward and says, no, I'm not ready to let him go. I want everything done. The doc will usually let everything be done because, they got to call in ethics consults and, but if a cohesive family unit comes forward and says, my dad did not want this, and they don't want tubes and they don't want CPR, or they want withdrawal of care, then healthcare providers are more likely to do what the patient wants.
Right.
So the uncertainty of all of the ifs, ands, or buts, if the family's not cohesive or the patient has been brutally clear in their living will, under this situation, I do not want this, and this, or I want it for 2 days, and if I'm not better, then take it out. That's how specific the living will has to be.
Yeah.
But so many patients complete these documents without fully understanding what they're signing or what prolonged ventilation might entail.
Right.
So we have to have a document that reflects intention, but it's almost no one has that in their living will. It's all just sort of signed. But there's a wonderful thing that can get past all of this, and that's the durable power of attorney for healthcare matters. That's incredibly important.
Yeah, that's really where durable power of attorney for healthcare becomes incredibly important, unlike a static document, right? It's designed
like the living will.
Exactly. It's a design proxy that, interprets the patient's values in real time. It applies them in evolving situations because patients' conditions do change. But, naming a proxy isn't enough on its own, I think, certainly in the conversation behind that designation, if you will, and what really actually matters. And without those discussions with patients and family, even a well-meaning proxy may even struggle to make decisions under pressure.
Especially if they don't understand the medical machine.
Right. And to your point, that you have to be very explicit. And so that can lead to choices really that don't fully align with what the patients actually wanted at the end of the day.
So I didn't know a long time ago, this is decades ago, I didn't understand that you could make a secondary durable power of attorney for healthcare matters. So my husband is my primary, and his final say is what matters. But he isn't in medicine. I could be having hair growing out of my tongue following a stroke, and he'll have a doctor come up to him and say, I think we can put in a central line and start dialysis. That might help her. And he'd say yes.
Yeah.
So I have a secondary durable power of attorney for healthcare matters. She's listed on my durable power of attorney for healthcare matters paperwork with Keith.
Wow.
But she is in medicine and she does understand everything. But she and I have sat down and discussed things to the nth degree. If I cannot speak for myself, I don't want IV fluid. I don't want tube feedings. I don't want a tracheostomy. I don't want dialysis. I don't want any of it.
Yep.
Because I don't want to be resuscitated to a suboptimal state.
Right.
And I'm going to turn 70 this year. I'm already kind of in a suboptimal state. I don't want to be any lower than I already am. But like we mentioned before, family dynamics play a significant role. And so your family members that can make the choices, and there's a list they go by. Your DPOA for healthcare matters is actually above your spouse.
Wow.
If you took the time to fill out the DPOA, your DPOA has first choice, even if it goes against the spouse. Now, again, if the spouse is, no, I want everything done, guess what the doctor will do? They'll delay withdrawal. They'll keep doing everything because they don't want to be sued. So even if a patient's wishes are documented, a single family member insisting on aggressive care can create delays. And the institution doesn't want to get sued. So they can prolong interventions that may not be beneficial. And from the provider's perspective, that creates a really painful and difficult situation where you're participating in care that is misaligned with the patient's values.
Yeah, Lynn, that kind of brings like emergencies. That adds another layer of complexity because they compress time, right? They limit access to information. Everybody's scrambling. I've seen this so many times. And you may or may not have the immediate access to valid directives, or the documentation may be unclear or outdated. And in those moments, the default is almost let's go ahead and act, right? Let's intubate, let's resuscitate, let's transfer to the ICU, put the dialysis catheters in, and the law really assumes that there's this time for deliberation where there's not. And emergencies definitely don't allow for, any sort of real-time thinking to assess, and because we're reacting right on the moment. So providers are also left navigating space where ethical clarity, if you will, and legal guidance don't always align in those times of duress, if you will.
I had a patient one day who had come in. He had been resuscitated at work, but his wife and daughter called and said he did not want this. And so they brought in his living will. They sat down with the doctor and the respiratory therapist. He was able to nod and blink his eyes to their questions, and he did not want this tube. And so they explained everything to the family and to the patient, but the RT came in and withdrew that tube, and his wife and daughter were by his bedside holding his hands as he passed. And I've also come to learn that there have been people who tattoo DNR on their chest.
Yep.
And that's not honored. Paramedics will still do full resuscitation if they're called to the house or you're in a car accident or whatever. You get full treatment. So unless you have your living will squeezed up in your fist, everything's going to be done. But hopefully if you have the living will that your family can bring forward, that won't be a long-term thing that you're stuck on machines. Because I think it's important to acknowledge that many of these challenges are not the result of individual failure, but of system design, that machine of the hospital system and medical system. But providers operate within these constant time pressure, these constraints, staffing limitations, dear God, are everywhere. And the norms, institutional norms that shape what is possible in the moment, code status, for instance. And even the most thoughtful clinician cannot control all of these variables. But within those constraints, we still have opportunities to communicate clearly and advocate for patient values and bring a little compassion into the process. I mean, these actions may not change the system, but they do make a difference for the patient and their family. So when it comes to communication in these situations, it's not just about delivering information. It's about helping people understand what's happening in a way that aligns with their emotional state. And again, the book goes into all of these different processes, questions to ask, things to know, paperwork to have. But there's one approach, if you don't have all of that, that can be very effective, and that's the ask, tell, ask framework. And it starts by asking what the patient or family already understands. And this will help us gauge their baseline knowledge. And then you provide information in a clear, direct way. And finally, you ask again to see how they're processing it. My 3.5-week-old daughter was in the emergency room at the hospital that I worked at. And they were talking to me. She had a fever at 3.5 weeks, and we knew it was bad. But the doctor starts telling us about what's next. And they said spinal tap. And the room spun. And I worked there, and I was only catching about every fifth word. So imagine people that aren't medical or nursing or in any way what they make of all of this. But the ask, tell, ask framework creates a dialogue rather than just a one-sided explanation.
Yeah, Lynn, you bring up a really good point, and I think clinicians really need to understand this, particularly our anesthesia colleagues, and I kind of harp on this a little bit. I go into work early every day, and it's not just to be, to set up my room. It's an opportunity to spend with the patients, because, that dialogue is critical. People that are in crisis only hear fragments, to your point, of what's actually being said. They're processing fear, uncertainty, sometimes shock, all at the same time. And if we move too quickly as clinicians or healthcare providers and rely on our technical language and jargon, and we really do risk losing, we do lose them entirely. So slowing down our conversations allows sort of the space for questions, for clarification, emotional processing. And, the reason why I do it is so that they hear the same thing repetitively. And I actually tell them, I said, I know this is a lot. And I know everything is it's like drinking the information from a fire hydrant. You're not catching all of this, right? And the reason why I'm doing this for you is because I recognize that. And I want to make sure that if you have questions, I can answer hopefully most of them. But what I can't answer, I can actually have, whether our surgeon or whether, whatever physician that's managing we can escalate that. And that helps build that trust, which is really, really essential in those times of duress.
Well, and it's not just talking. It's silence. It's listening.
Yeah.
Even though that can feel pretty uncomfortable, but by giving the family, the loved ones, a moment to process what we're saying, we don't need to fill space with action or definition or explanation. Silence allows patients and families to absorb what they've just heard and to respond in their own time. It communicates presence without pressure, which can be really powerful. And sometimes the most meaningful support we offer is simply being there without trying to fix the situation.
Yeah, and I think in combination with that is when we do speak, that we also have to be mindful of the language that we actually use as clinicians. And especially when it comes to reassurance, right? Phrases like, everything will be okay, might not, it's well intended, but that can really create confusion or unrealistic expectations. I'm very cautious about that when it's like, oh, the patient will be fine. They'll and it's, you can't guarantee that. You don't know. And I can't tell you the times that I've gone back to the operating room with a patient and it wasn't fine, right? You open the patient up and it's like, this is a no-go. We cannot do this.
Right.
So instead, we kind of transform that sort of conversation where we offer statements that are really honest and grounding. And it sounds like, we're here with you. We're going to support you through this. This kind of language really acknowledges that uncertainty, because we cannot guarantee 100% certainty of what the outcome is going to be. But we certainly can provide comfort for that family and that patient.
And by being open and saying, no matter what, I'm going to be there with you the whole time and do everything I can to make sure that you're safe.
Yes.
I think that families and the patient, they may not have the best diagnosis, but knowing that you care, I think says an awful lot in reducing the level of anxiety, that you're not just one wheel in the cog, that we're paying attention to absolutely you and your family and to do the right thing. So ultimately, compassionate communication is about presence, clarity, honesty, and it's about meeting people where they are rather than trying to move them to where I want them to be. But like any clinical skill, it improves with practice and reflection. And when we approach these conversations this way, with intention, we're not only supporting patients and families, we also create a more meaningful connection to our work.
Absolutely. And that emotional toll of this work, is something that often goes unspoken, and it's very real. Providers are constantly navigating these high-stakes situations, as we've discussed. And when those situations involve death or poor outcomes, the impact is profound, not only on family, patient, but also as the clinician who's the caregiver at the moment. So, it's not just the individual event, it's the actual accumulation over time for us as providers. In each case, each conversation, each moment of uncertainty adds to that overall weight or emotional burden that we as clinicians also carry. And without a way to process that, it can lead to things like burnout, emotional fatigue, be very disruptive, not only at work, but also at home, because we take it home, right?
Absolutely. And that carries heavily, even if you're not thinking about it directly, the weight of that, it's just you're dragging yourself through the door because it is carried privately. If your family doesn't know what you do, really, truly, you have to handle all of that on your own. And there's an expectation at work to remain composed, to move on to the next case, to not let it affect your performance. It's this machine. But that doesn't mean the experience disappears. It just becomes internalized. Over time, that can lead to feelings of isolation and self-doubt and even a loss of connection to the work itself. It's a quiet erosion that many providers don't recognize until it's significant, and then you're just on the floor.
Yeah, and so this all kind of, and there is a podcast we've done, and we'll allude to it again. This is that second victim phenomenon, and it highlights this experience in a very specific way where adverse events occur. Patients and families are really the primary focus, but the clinician involved may also experience significant emotional distress. We've all experienced it. And that can include things like guilt and shame and anxiety and heightened sense of responsibility that can depression and in some cases it'll affect your physical well-being and your sleep, and so you don't get good sleep, and this just starts to snowball. And so these experiences are really rarely addressed in structured or supportive ways, and why you need to have a program in your environment that is able to kind of protect and adapt your clinicians through this in a supportive way. And Lynn, you bring it up, when there's an intraoperative death or a death that a clinician is involved with, we have a program that I put together, it's been over 10 years ago now, maybe 15 years ago, and crisis incident stress management. And so the group,
that's a good term.
Yeah, the group self-selects who they want as their peer advisors, right? So there's control within the group. And so when there's an event, we take one of those peer advisors and they take that clinician and go for a coffee, and they kind of just rehash, and it's a system approach. It's not like, oh, well, how in the heck did you give the wrong antibiotic and create, it's not that. It's like, what do you think was the issues that maybe led or contributed to that event? And then we look at system opportunities for improvement, right? Like, was the label different? Was it in the wrong pocket in the Pyxis machine? I mean, that's the easiest one to kind of pick on. But then we do a debrief with the entire team. And then we offer, employee health and some of those resources, but we do not put the clinician back into clinical services.
Right.
That day they are removed, and maybe even the next day, depending on the gravity of that situation, they are still not necessarily put into clinical services. They might be brought in for breaks. They might be given the day off.
Right. Even if they insist on going back in the room.
Oh, yeah. I'm okay. No, I'm okay. No, you're not.
Yeah. I think it's important to say, time out. And not that you're being punished in any way, but you just need to take a break.
That's right. Yeah.
But I think debriefing is so important,
Absolutely.
Not just from the clinical standpoint, but from the emotional one. Having a space to talk about what happened, how it felt, and answering any questions that remain can really make a significant difference. That's what happened with a colleague of mine who had an intra-op death in the GI room. And he sat there in our break room all day, and people would come in on their breaks and listen and give him hugs. And he was able to cry and go through talk about what he was going through.
Yeah.
These conversations need to be non-punitive and supportive. And this allows providers to process without fear of judgment and being picked on or anything like that can happen. Peer support, mentorship, informal conversations with colleagues, all of this plays a crucial role in recovery.
Are you looking to transition into independent practice? AANA and Beyond the Mask are here to help you thrive as your own boss. Visit the 1099 CRNA Institute, taught by Beyond the Mask host Jeremy Stanley and Sharon Pierce. This comprehensive educational series provides detailed guidance on business structure, legal and tax implications, and financial management tailored specifically for 1099 CRNAs. Lean into the feeling of freedom and embrace the opportunity to be your own boss, with AANA as your partner on this exciting journey toward independence. Enroll now and gain the knowledge you need to navigate the business side of independent practice. Learn how to choose the right business structure, understand tax strategies, and manage contracts and finances with confidence. Plus, enjoy a special 20% discount using the code BEYOND1099 at checkout. Visit aana.com/1099 to learn more and start building the future you want. The 1099 CRNA Institute. Thrive as your own boss. Remember to visit aana.com/1099 and start using the code BEYOND1099 for a 20% discount.
Let's not forget, institutions have a responsibility here as well, right? I mean, creating systems that really recognize the emotional impact of patient care, providing access to resources or support, allowing time for recovery are all essential. And you know, when clinicians feel supported, they're better able to provide compassionate care. Their level of engagement is sustained, you know, and supporting providers is not, you know, optional. It's really an ethical obligation from all vantage points, institution, departments, etc.
And colleagues too. Just having everybody come in and saying, you know what, I need to talk to somebody. I'm going to call the employee assist program and just sort of process this, and having your colleagues go, yep, that's the best thing you can do for yourself. What else can we do for you? Let's go for coffee. But let's talk about on an individual level. I think it's important to acknowledge my own response to these experiences, to recognize that the feeling affected is normal and that seeking support is a sign of strength and not weakness. This work asks a lot of us, and we need to be intentional about how we care for ourselves within it. So there's several aspects of end-of-life care that are often overlooked, and even though they significantly influence the experience for everyone involved, we don't always look at it. But cultural and spiritual beliefs, for example, can really shape how patients and families understand death, what they expect, how they make decisions. And if we don't take the time to explore those perspectives, we really miss something essential. It's not just about medical care, it's about meaning.
Yeah, you know, Lynn, and I think in addition to that, you know, team dynamics are another important factor that, you know, doesn't always get enough attention. You know, different specialties bring different perspectives. Those perspectives don't always align. And, you know, we look at surgeons, anesthesia providers, ICU teams. They may all have different thresholds for intervention or a different interpretation of the prognosis. I've seen that many times, right? And so when communication between teams is even limited, that can also create confusion and conflict, especially when we get to what we talked about, those high pressure situations.
High pressure, yes. But timing is also critical.
Yeah.
And unfortunately, many of those conversations happen too late, and that's what we discussed. You want to have these conversations before a crisis. And when discussions about goals of care are delayed until a crisis, options become much more limited and emotions are much more intense. Earlier conversations, especially in the preoperative setting, can provide clarity and eventually, or even presently, reduce the burden on families later. It allows decisions to be made with more thought and less urgency and more communication.
Yeah, and and there's that internal impact of how repeated exposures to death actually will shape us over time. For some providers, there's a gradual loss of empathy, and often and that's your protective mechanism.
Right.
And and that doesn't all happen at once, but over time, there might be this increased detachment, cynicism. I've seen even in the ICU where you're on a run of a lot of deaths, a couple of deaths a night, and then when that repetitively starts to occur, there is, and I've witnessed this, and I remember a patient coming out, not a patient, the patient family member coming out of the room to the main desk in the ICU saying that, your group is very insensitive. My loved one is dying, or they're very ill. So I pulled the guy aside, I think it was the son. I said, look, this is nothing against your family member, and this is nothing against you. I said, my nurses go through death and dying every single night. And one of their coping mechanisms is they have to be able to laugh. And I get it. It doesn't feel like it's the right place for it. And I don't know what that balance is, but you don't want your providers to get emotionally and physically destroyed because they're empathetic and crying at every single It's not optimal. And I think we all as human beings recognize it, but you have to be able to process. And so that distance, I think in some providers' minds, perhaps maybe helps sort of strengthen the meaning of the work that they do, if you will, because let's face it, we can't always be, in these unfortunate times and crying and depression, and that's
crying in our soup. It helps no one.
It does. Yeah, it doesn't.
I know when I was an EMT, I was appalled when I first started at their sense of humor. And within weeks, I totally understood it, because you see the most horrible things in street medicine, and you either learn to laugh or tell jokes or roll your eyes or something. This guy's arm, he had it hanging out of the driver's window, and he got it completely cut off when a truck went by. And the paramedic had to run back and get it off of the street. And he came into the back of the ambulance, and he's holding up the arm, and there was a Timex watch still on his wrist, and said, took a licking and kept on ticking. And I was so mad. But again, in a couple weeks, either you learn to not make light of it. You're not laughing at anybody.
No.
There has to be some level of release, or we'd all end up on heroin.
Yeah.
It's just too much.
It is.
But many providers experience the opposite of a deepening of empathy and a stronger connection. They develop the ability to sit with patients and families in difficult moments without needing to fix everything.
Oh, it's so important.
That kind of presence is not something you're born with. It's something that develops through experience, reflection, support. It represents a different kind of strength, but can be incredibly important for the patient and families.
Absolutely. And I think the difference often comes down to whether, providers have the space to and the support to process the experiences that they go through. And, when that support is present, empathy can be deepened rather than eroded, because there's that level of connection that's allowed to be built with that patient-clinician relationship. And that has a direct impact on patient care, ultimately, team dynamics, and personal well-being of that clinician. And it's something we should actively cultivate and not just leave to chance. As we come to the end of sort of this conversation, it's clear that this topic will actually extend beyond clinical practice. It touches, on how we think about life, about care, about our role as healthcare providers. And Lynn, I'd love for you to share sort of how this connects to your upcoming book, because I think it really feels like a natural extension of everything that we've discussed here today.
And I'm so thankful to be able to do this. I think this is so important. And again, you want to do this before a crisis occurs. But this work has really shaped how I understand death, not as a failure, but as a part of life, a natural part of life that deserves the same attention and care as any other phase. Because, as the title of the book says, it's not if, it's when.
Yeah.
Talking about it doesn't make death happen faster. The importance of reframing death as part of the care continuum rather than something separate from it can really shift how we approach patients, how we communicate, how we process our own experiences, and how we can help our families and loved ones prepare for my passing, for my end days, for their families' end days. It allows for a more honest and compassionate form of care.
Yeah, and I think ultimately for clinicians, it takes, some of the pressure off that idea of needing to control every single outcome, because when we accept...
Well, we can't.
And we can't, right. But when we do accept that not everything is controllable, we can then actually focus more on how we show up in those moments of duress of patients and families. And that's where I think the real impact is. I can't tell you how many times I have witnessed clinicians that were probably not in the bucket of elite, right? Maybe marginal would be the bucket they would fall into.
I don't know what that means.
So
the bucket of elite?
Elite. The bucket, like they're not the highest performing clinicians, right?
Got it.
They are marginal at best, but their bedside manners and their ability to communicate with patients is off the chart. And patients will rave about those clinicians because they don't care about the perfection, right? In many instances. Obviously, they want to come in, have their intervention done and be done with it. But when they're sick and you're getting, and I think about, pediatrics with retinoblastomas or some of those conditions to where the child will die. And I think what's most important to the family and obviously the child is how the clinicians interact and take the time to sit and listen to the patient and the family members. And
instead of avoiding the room because it's too heavy.
Right. It's very powerful.
And healing, but not just for the family. It's healing to us to be able to be sincere and authentic in a way that is helpful to other people when they need it the most.
I think one of the most important takeaways here today, that it isn't just something we encounter professionally, it's something that we should consider personally, as you've said, as well as you've outlined in your book. Having your own directives and having conversations with your loved ones, thinking about what matters to you, those are really all the parts of understanding this from both sides, not just as clinicians, but as family members.
And humans.
And humans, yes.
Well, because ultimately this work shapes us too. It certainly helps the family and the patients, but it shapes us. It influences how we see life, how we relate to others, and how we practice. And taking the time to reflect on that is part of being authentic, thoughtful, and an intentional provider. So I'd like to thank everybody who's listening today. Thank you for being part of this conversation. It's very important to me that we talk about this. I hope that this information helps you.
Yeah, and if this episode resonates with you, we encourage you to continue that conversation with colleagues, with friends and loved ones, and even within yourself. These are not easy topics, but they are important ones. And they do deserve a space where we need to talk about it.
Very important. May I say though that, and this isn't just about selling a book. This is about getting the information out there. But my books will all be listed on Amazon. It's not if, it's when. And it's also on our my personal webpage, alwayswithyou.com.
Excellent.
Thank you for letting me talk a little bit about what I've written in my book and the importance of the roles we play in helping other people, either in the ICU or in the operating room.
Absolutely. Well, thank you for sharing all of the stuff and your book with us, Lynn. Well, to those of you that are listening today, we encourage you to jump on over to the website at Beyond the Mask. The clinical edition is the Anesthesia Alchemy, Lynn and Garry Unplugged. And, give us a like, give us a comment. If there are other things that you'd like to hear, certainly shoot us an email, and we'll certainly cover that content for you. So with that, thank you for listening and joining us.
Thank you.
All right. Until the next episode, have a good day.